What if I told you that the answer to your ongoing arthritis flare-ups isn't in a higher dose of your biologic, isn't in about switching medications for the third time? It might be something that everyone is talking about. Ozempic, Wegovy, Mounjaro, or Zepbound. I know you know these names. You've probably heard them many times in your newsfeed, in the talk shows, or maybe in some conversations with your friends. But here it is, what the conversation is completely missing, and what I'm seeing every single week in my rheumatology practice. These medications, even at the very small doses, may be among the most powerful tools that we have right now to bring arthritis and autoimmune diseases under control. I'm Dr. Girnita, a rheumatologist with over 20 years of experience. And for the past 3 years, I have witnessed changes that are truly remarkable in my patients using these drugs. In this video, I will tell you exactly what is happening inside your body when the arthritis, autoimmune diseases, and weight intersects. Why the standard approach of just adjusting your DMARD or a biologic is sometimes missing this critical piece. What is the brand new science say about these medications? And we will talk about disease by disease. And I will also tell you why these even small doses of these medications can change everything in your treatment plan. Let's get into it. Let me introduce you to the family of Ozempic, Wegovy, Mounjaro, and Zepbound. And I will start by clearing up the confusion, because every week in my office, patients are mixing up these names, and it matters. The lower dose version approved for type 2 diabetes, while Wegovy is the higher dose version approved for obesity and weight management, because these are two molecules that we are going to talk about. The first is semaglutide, and that's the ingredient both inside Ozempic and Wegovy. Same molecule, different doses, different FDA labels. The second one is tirzepatide, and that's the ingredient inside both Mounjaro and Zepbound. Mounjaro is diabetes. Zepbound is obesity. Again, same molecule, but two brand names. Now, here it is what is clinically important as a difference between these two families. Semaglutide activates one receptor, GLP-1. Tirzepatide activates two receptors at the same time, GLP-1 and GIP. The dual action makes tirzepatide more powerful when it comes to weight loss. And a 2025 meta-analysis, it showed that it can reduce key inflammation markers like C-reactive protein and IL-6. And we are talking about roughly 33% reduction in C-reactive protein and 18% reduction in IL-6. So when I say GLP-1 medications in this video, I mean the entire family. But semaglutide and tirzepatide are the ones that are generating the most excitement right now. And this is for a good reason. But let me ask you something. Why would a metabolic medication have an effect on inflamed joints? And the answer starts with something that is happening inside your fat cells. And once you understand that, your entire picture about arthritis will change. Obesity and arthritis are not two separate problems. They share the same root, and that root is chronic inflammation coming from your own fat tissue. And here it is something most patients have never been told. Honestly, sometimes many doctors don't fully connect the dots either. If you have arthritis and you carry some extra weight, those two things are not independent. Your fat cells, meaning that your adipose tissue, is not sitting quietly there just to store fat. These fat cells are biologically active, and they are producing a constant stream of inflammatory chemicals that we call cytokines. And I'm talking specifically about IL-6, TNF-alpha, IL-17, and IL-1. And here it is why it matters. Those are the exact same molecules that will drive rheumatoid arthritis, psoriatic arthritis, and lupus. And they are the same molecules that those expensive biologic medications that we are using are designed to block. So picture this. You are on a biologic medication that is trying to quiet your inflammation. But at the same time, your fat tissue is continuously pumping those exact inflammatory molecules back into your bloodstream around the clock, every single day. And that's why in many patients with rheumatoid arthritis and psoriatic arthritis, the biologics and DMARDs could work just partially. And this is not because the biologic is wrong. It's actually because the metabolic inflammation is undercutting the effect of the biologic. Now, obesity have been shown in multiple studies to reduce the effectiveness of DMARDs and biologics. And in some patients, it actually literally blunt the effect of the drug without people realizing it. And that effect doesn't stop to the joints. This chronic inflammation travels to your heart, to your blood vessels, to your kidneys. And patients with rheumatoid arthritis and lupus already carry an elevated risk for cardiovascular disease away from their disease. And just adding this metabolic inflammation on top of the inflammation that comes from arthritis, you will have a compounding problem is not addressed at the root. So that is the missing piece, not the fact that you need a higher dose of a biologic, just treating the metabolic inflammation at the source. Now, what do Ozempic and Mounjaro actually do about this? Because it turns out that they work on inflammation through 5 completely different pathways. And some of them work without losing a single pound. GLP-1 and dual GLP-1 GIP medications attack inflammation through at least 5 separate mechanisms. And one of them is completely independent of weight loss. And this is the part that most doctors are not explaining yet to their patients. But I want to be very specific. Number 1, cutting the fat-driven inflammatory supply. When you lose 5 to 10% of your body weight on Ozempic, Mounjaro, or Zepbound, that can dramatically reduce the IL-6, TNF-alpha, and IL-1 output from your fat tissue, which means less metabolic inflammation fuel, and then your biologic or your DMARD will immediately work better. Number 2, a direct anti-inflammatory action which is independent of the weight. And this is the one that is changing the entire field of rheumatology. A research published in the Journal of Clinical Rheumatology in 2024 confirmed that GLP-1 will inhibit the NF-kappa B pathway, which is one of the master switches of inflammation. And this was demonstrated directly in rheumatoid arthritis and psoriasis cell models. The drug is turning down inflammation at the molecular level, even before you lose a gram of weight. And this means that even a small doses, what we call microdosing, can have a meaningful anti-inflammatory effect in patients who have arthritis but are not obese. Number 3, restoring your gut health. There is an established gut-joint connection in autoimmune diseases. A disrupted gut microbiome will generate immune activation that will reach your joints. Now, GLP-1 medications will improve the gut microbiome diversity and will reduce the gut permeability. And research published in Science in 2025 even identified a specific gut-joint axis via the bile acid metabolism, through which GLP-1 medications will directly protect the joint cartilage and will reduce osteoarthritis, which is the wear and tear arthritis. Number 4 mechanism, reversing insulin resistance. Now, many patients with rheumatoid arthritis, psoriatic arthritis, and lupus have insulin resistance, and they are completely unaware about that. And insulin resistance feeds the chronic inflammation cycle. And both semaglutide and especially tirzepatide with its dual action will break that cycle very powerfully. Number 5 mechanism, reducing oxidative stress and protecting the cartilage. Oxidative stress accelerates cartilage destructions, especially in osteoarthritis. And GLP-1 medications will reduce the body-wide oxidative stress, and that will help you protect the joint structure beyond just reducing the pain. Now, this message here is layered. These are not just weight loss drugs. They are metabolic modulators with direct anti-inflammatory properties. And the evidence comes from these 5 distinct pathways. And here it is where the clinical picture gets really exciting, because what the 2025 research is now showing us, disease by disease, is something that I personally didn't expect to see so quickly. The data that was presented at the American Congress of Rheumatology in 2025, but also peer-reviewed journals in the last 2 years, is rewriting the treatment conversation for rheumatoid arthritis, psoriatic arthritis, osteoarthritis, for gout, and even for patients with lupus. Let's start by talking about rheumatoid arthritis. And here it is a study that every rheumatoid arthritis patients need to know about. It was published during the last ACR meeting, and researchers from UCLA followed 173 rheumatoid arthritis patients who were started on semaglutide or tirzepatide between 2018 and 2024. And they compared these patients with 42 rheumatoid arthritis patients who were prescribed the drug, but they chose not to take it. And after 1 year, the patients who took the medications had significantly lower rheumatoid arthritis disease activity, plus a meaningful drop in pain. And that was compared to the control group, which actually got worse pain. The patients who took the drug, the GLP-1, had also CRP and SED rate fell down, had cholesterol improved, and their weight dropped with an average of 4.4 kilograms compared to 1.2 kilograms drop in the control group. And this was all statistically significant. Another study in over 12,000 rheumatoid arthritis patients found out that people who use semaglutide had significantly less joint pain, less stiffness, less swelling, and less synovitis at 30 days, at 3 months, and even after 1 full year compared to those who didn't use the drugs. And the researchers attributed this partly to direct immune modulation to reduce inflammation and not just to weight loss. But here it is the clinical takeaway. The GLP-1 medication does not replace your biologic medication or the DMARDs medication, but it can make that existing treatment work significantly better. And for some patients, it can create the possibility to actually reduce the drug burnout. Rather than escalating the drug, you can slowly reduce the doses of the drug. Again, with your rheumatologist. Let's talk about psoriatic arthritis. And I'm going to tell you the story of one of my patients, Daniel. He is a real patient, 33 years old, 280 pounds. He had 10 years of psoriasis and psoriatic arthritis, and he failed multiple medications. And a few years ago, I had him on a weight-based biologic infusion, and even that was not giving him the adequate control. But about 3 years ago, I started him on a GLP-1 medication, and within a couple of months, his skin began to clear. His joint pain came down. His morning stiffness improved significantly. And by the 6 months mark, his disease was better controlled than it was in a decade. And that was not because I replaced the biologic. That was because we reduced the metabolic inflammation, which was making that biologic not working as was supposed to do it. And the 2025 ACR Congress showed us some studies about psoriatic arthritis, which confirmed exactly what happened in Daniel's case. A study in 48 patients with psoriatic arthritis on a GLP-1 medication showed that not only did they reduce the weight, but they also had a great improvement in their joint pain with lower disease activity and decreased markers of inflammation like C-reactive protein. But there is another study that I want to tell you about, which was led by Harvard researchers, which showed that people using GLP-1 drugs had a significantly reduced risk to develop new psoriatic arthritis when compared to patients that were taking other drugs for diabetes. And then here is something important. These drugs, the GLP-1 medications, if they are used in patients with psoriatic arthritis, they seem to reduce the cardiovascular risk, which means that these patients will have fewer heart attacks, fewer strokes, and fewer deaths because of heart disease. And you probably know that psoriatic arthritis already will increase your cardiovascular risk. And this study showed that GLP-1 can save lives. And this is not just about joint pain. This is about protecting your heart. Let's talk about osteoarthritis. A study published in New England Journal of Medicine in 2024, which enrolled over 400 patients with knee osteoarthritis and obesity across 11 countries, showed that patients on semaglutide lost about 14% of body weight versus just 3% on placebo. The pain reduction went far beyond the weight loss alone, and their knee pain score dropped 41 points versus just 27 points on placebo. And the physical function improved significantly in these patients who took the GLP-1. And this becomes a landmark study because it changes how orthopedic surgeons and rheumatologists will think about how to manage osteoarthritis before we offer options like surgeries to patients. Now let's talk about gout. And I have to give you a full, honest history because when it comes to gout, the situation is a little bit more nuanced. When patients first start GLP-1 therapy and they lose weight rapidly, the uric acid can temporarily increase because the breakdown in fat will release purines and they will go into the bloodstream and that will convert to uric acid. And this can trigger a gout attack. I have seen it, the research will show that, and it is real. But here it is what it matters. This is short-term effect because the long-term data supports that the fact that once the weight stabilizes, the GLP-1 medication appears to lower the uric acid and it will reduce your flare-up frequency. And if you had bariatric surgery, the same happens in that situation. And that's why managing this transition requires a rheumatologist, not just a weight loss clinic, because you need someone who knows how to treat gout and who also know how to use the GLP-1 medication. Now let's talk about lupus, Sjögren's, and ankylosing spondylitis. The evidence there is still small, but it is growing fast. There are some small studies in lupus that show that patients with GLP-1 therapy have less flare-up, and also that the GLP-1 medication may slow down the progression of kidney disease in patients with lupus nephritis. There are also studies that will show that GLP-1 medications will associate with a significantly reduced risk to develop new autoimmune diseases in general. But when it comes to patients with Sjögren's and ankylosing spondylitis, we still don't have data. But the science is accelerating. And here it is the conversation that I want to have that nobody has so far because it's going to change who this medication is for. You don't have to need major weight loss to benefit. Microdosing GLP-1 medications means that small targeting doses may be the key for patients with arthritis or autoimmune diseases who are already on treatment, but they are not fully controlled. This is the part of the conversation that I find most exciting and mostly underused in our rheumatology practices as we speak today. When most people think about Ozempic and Zepbound, they just picture the significant weight loss. They think about big doses and they think about the major metabolic transformation. And that is valid for many patients. But here it is what I see in my clinic. And I think this is genuinely underappreciated, even at small doses. What we as clinicians are calling microdoses, we are producing a meaningful clinical improvement in arthritis and autoimmune patients. What does it mean practically? It means that instead of pushing to the full therapeutic dose that is designed for obtaining a maximum weight loss, some patients that are started at a very low dose, just enough to begin modulating the metabolic and the inflammatory pathways without changing their appetite and without changing their weight, I have remarkable results. Let me tell you about the story of my patients. I had a patient from Arizona. She was maximized on rheumatoid arthritis treatment on both DMARDs and a biologic. But she still had multiple flare-ups for months. She was exhausted and in pain. 4 months after starting her on a GLP-1 microdose, her flare-ups dropped from multiple per month to 1 per month. And her energy improved significantly. And now we are actually tapering down her doses of medication. Not escalating, tapering down. And why does it work? Because as we just talked, the anti-inflammatory effects of these medications operate through pathways that can independently be away from weight loss. You don't need to lose 14% of your body weight to get that anti-inflammatory benefit. As I said, even a smaller dose can get a consistent metabolic signal, can reduce the fat-driven cytokine output, and will calm down the immune system that is actually activated and can undermine the effect of your biologic or the effect of your DMARD drug. And this approach is especially relevant for patients who are not significantly overweight, but they have that metabolic inflammation. Patients that have insulin resistance, prediabetes, who have elevated C-reactive protein, and who are struggling to achieve full disease control despite that adequate drug dose of the medication. But the key message that I want you to take home: before we escalate your arthritis medication, before we switch to more aggressive biologic, before we increase that DMARD, the question that I now ask in every patient that I see in my clinic: have we addressed the metabolic inflammation? Because if we haven't, we are managing the fire while we are leaving the fuel on. But let me bring this together to you. Ozempic, Wegovy, this is semaglutide. Mounjaro Zepbound, this is tirzepatide. These medications are not replacing your DMARDs or your biologics, and this is very important. I want you to remember that. But they are emerging as one of the most powerful complements to your arthritis treatment that we have right now, because they address that metabolic inflammation that usually in conventional rheumatology treatments we don't touch. And even the big research academic centers, they recognize that. Places like UCLA and Harvard, they all point into the same direction. Using these drugs, you can have less joint pain, fewer flare-ups, lower cardiovascular risk, and better response to whatever medication you are already using. And for a carefully selected group of patients, even microdoses can produce real, measurable, life-changing results. And if you have arthritis, and if you feel like you have been stuck, your medications are doing something but not enough, your flare-ups are keep coming, you are fatigued, and that doesn't go away, there may be that metabolic piece of the puzzle that nobody has addressed yet in your case. I hope to see you in my next video.